Good morning. Welcome to the CAC2 webinar, Improving Time to Diagnosis for Pediatric and Young Adult Cancer Patients. I'm Robin French with the Morgan Adams Foundation. Hope everyone is well today and looking forward to summer. Those of us here in Colorado are still in the midst of pseudo-spring. We had a little snow this week, so hope y'all are getting actual spring. We've had a really busy week here at CAC2. Thanks to everyone who attended the training last night that was co-hosted by CAC2 on state cancer plan advocacy. We're glad to have those of you who did last night back again today. We don't usually schedule things back to back, but they were both very important, and we're so glad that you've taken advantage of these opportunities. Everyone who registered for last night's event will receive the recording and slide decks by email later today. Just another reminder that registration is open for the 2021 CAC2 Annual Summit, and it's the afternoons of June 24th and 25th. The theme this year is Putting Cancer Kids First in a Post-Pandemic World. The CAC2 meetings team has designed an excellent program that will balance the expert content presentations with opportunities for active engagement for the attendees. And the program promises to be quite lively and interesting as always. The registration link will be in your chat, and you will have that close at hand. Or you can go to cac2.org, and there's an annual summit banner at the top of the website. I want to thank Ann Raymer, who is my usual webinar partner and who normally makes these announcements. This month, she finished graduate school and started a new job. It's been quite busy, and she's been doing some onboarding for her new job this morning. So I wish her all the best and congratulations. I want to remind everyone that you are on mute for the webinar. If you have questions, we will take those at the end. Please feel free to note those in the questions box in your control bar, and we will ask those of the presenters. This webinar is being recorded and will be available to the members. Also want to let you know that if you have suggestions for future topics, we're always happy to hear those, and please bring them to the webinar team. And somehow I'm missing the CAC2 value slide, so I don't have them memorized. So I think we might have to come back to that. But we are fortunate to have Dr. David Walker here to present on the Head Start program that they have in the UK to provide early diagnosis of brain tumors and what we can learn from him. Stephen Crowley and his wife Cynthia are here to introduce Dr. Walker and get us started. Thank you.
Thank you, Robin. And thanks for joining us today. So I'm Steve Crowley. I'm a former board member of CAC2, and I'm joined here by Cynthia, my wife. And we've had long been concerned about delays in pediatric cancer diagnosis. And thanks to CAC2 and what CAC2 aims to do, which is bring like-minded people together, we were able to meet Susan Gusto, the founder and president of the Friends of Catherine Foundation, as well as Amy Sapien, a medical social worker based in Florida. And well, all of us have been directly impacted by late diagnosis of pediatric cancer, and we know we're not alone. We've also been frustrated by the lack of attention on this issue in the US, but we've also been greatly encouraged when we learned about the progress on this issue being made in the UK. And that brings us to our first speaker today, Dr. David Walker. Dr. Walker is Professor of Pediatric Oncology Emeritus at the University of Nottingham in the UK, where he headed the Children's Brain Tumor Research Center. And from there, he launched the program of the Head Smart campaign to raise awareness about the symptoms of brain tumors and to create guidelines to reduce their delays in diagnosis. Dr. Walker will tell us more about the success of this campaign, which has now been expanded to pediatric cancer generally through the Child Cancer Smart campaign. We'll then hear from Dr. Scott Coven, Dr. Koven is an assistant professor of pediatrics in the Division of Pediatric Hematology Oncology at the Indiana University School of Medicine and the Riley Hospital for Children. He's the medical director of the Comprehensive Pediatric Neuro-Oncology Program and has a special interest in cancer survivorship and public and global health. He is active in promoting awareness of brain tumors in children, as well as employing technology to improve the quality of life for childhood cancer survivors. So Dr. Koven will share his work in bringing the insights of the Head Smart campaign to the US. And after hearing from our speakers, we'll turn to Susan Gusto, and I will also conclude with some thoughts on how the CAC2 community might get involved in expanding these efforts in the US. So with that, it's my great pleasure to turn things over to Dr. Walker.
Well, thanks very much, Stephen, and thank you to CAC2 for inviting us to talk today. I work with a senior trainee in pediatric emergency medicine called Shana Shanmugavadivil. Now, I think she may be attending, but not on the panel. And she and I, over the last 2 or 3 years, have worked closely together. And so I really acknowledge her contribution to some of the information I present today. As you pointed out in your introduction, Stephen, that diagnosis is a key point for all families when their child has a cancer of whatever sort. And it often, at that moment when they're being diagnosed, they reflect back on the journey to their doctor and the steps that happened along the way. And sometimes they look back and say, could things have been done better? And I wrote a report in 1997 in the UK about setting up a children's cancer network for children with brain tumors, with neurosurgery and oncology working together. And in that document, I looked at the evidence for delays in diagnosis for childhood brain tumors. And there were just 2 or 3 papers there saying in the UK, it was taking about 3 months on average to make a diagnosis of a brain tumor based upon a few small cohort studies. And that set me on this pathway. And so what I'm going to do today is really try and achieve 4 things. I'm going to talk about the childhood cancer route to diagnosis, now recognized as a global health priority by the WHO. I'm going to demonstrate the link between normal tissue growth rates in children and childhood cancer risks at different ages, because we believe that it's the rate of growth of different tissues that's driving the cancers in the particular organs where they arise. I'm going to identify the key elements of success of the Head Smart campaign for brain tumors and highlight an awareness tool that we're now going to further develop within our Child Cancer Smart project, which is intending to address the issues of delay for all childhood cancers, not just brain tumors. At the beginning, I'd like you to start writing on your chat forms your ideas of benefits you could see if diagnosis in childhood cancer was to be accelerated in your country. And if you could write things that you think might benefit if that started to happen. And by the end, I hope you will be in a position to announce what you might be doing in your own personal sphere of influence or your own organization to take this agenda forward within your own state or nationally, depending on your connections. If I can have the next slide, please. Could I have the next slide, please? Thank you. So Head Smart, go back. Head Smart is, could I go, that's right. Head Smart, early diagnosis of brain tumor, is our current logo for our current project. And we set this up because of, as a clinician, meeting many families who had a long story to tell, and we felt we should try and do something about it. And so we applied, I will tell you how we went about it. I want to point out the picture on the right there. There's a gentleman standing wearing a tie, talking to me in my white jacket, and the team I work with are all listed there. And Shana's that very petite girl standing next to him. That guy in the second from the right is the Director General of the World Health Organization. You will have seen him on television connected with the COVID programs globally in the last 2 years. He was a Nottingham graduate from my university. He did his PhD in community health there. And he was invited by my university to come and make awards at the degree ceremony 2 years ago. And I had the privilege of meeting him before COVID, and we were able to talk to him about the Head Smart campaign. He, as Director General of the World Health Organization, was very aware of the needs of children with cancer globally. And he'd already made the agreement with St. Jude's Children's Research Centre to develop a collaborative funded program to raise awareness of childhood cancer, because he was aware of the discrepancy between some countries' outcomes and other countries' outcomes. Next slide, please. Could have the next slide, please. So this is important because the WHO had never previously focused on cancer as a priority for global health. They always had focused on infection and socio-economic problems. And this is their report dated 2020, and this is some of the information from the component about childhood cancer. So not only are WHO focused on cancer, but they're focused on childhood cancer, and this is now recognized as a global priority. So this is I think it's important, if you do get engaged in this, to recognize that you would be part of a global initiative, and leading countries such as the United States need to take their role. But things aren't perfect in our leading countries, and they're even less perfect in the developing countries. I said the second aim of my talk today was to talk about the relationship between tissue growth and the sorts of cancers that occur in children. In the top panel there on the right-hand side, that's a graph showing the proportional increase in different tissues growth in the first 20 years of life. And you can see the top curve there is lymphoid tissue. That grows by 200% in the first 10 to 12 years of life. So when you're born, you have almost no lymphoid tissue, and by the time you're 12, you have 200% times more. And if you look at the commonest cancer in childhood, it's lymphatic leukemia. And so I'm making a link here between the amount of tissue growth and the sorts of cancers that most commonly happen in children. The second biggest percentage increase in tissue volume and weight is in the brain. And the second commonest group of cancers in childhood are in the brain. So the total body growth is the third line, the purple line, that's general growth. And you can see the purple line for bone tumors mirrors that growth. And then genital tumors, which are ovarian tumors and testicular tumors, principally happen around adolescence. And you can see that that correlates with their period of growth during adolescence. So the timing and frequency of tissues of origin in childhood cancer are linked to the rates of normal tissue growth. And this is really important because instead of everybody saying, oh, cancer is very rare in childhood, the answer we should all be using the concept that cancer is kind of an unavoidable complication of growth that affects a small proportion of children, but is entirely predictable. So this is the statistical data to say what's your risk of getting cancer by different ages. The bottom line you can see by age 1, your risk of getting cancer is about 1 in 5,000. By the time you're 5, that's multiplied by 5 to 1 in 1,000. So your greatest risk of getting any cancer is in the first 5, the biggest change is in the first 5 years of the life, perhaps because of the massive amount of tissue growth that's happening during that period of time. By the time you're 15, your risk is 1 in 470, and by the time you're 20, your risk is 1 in 300. So you can see that the risks double and triple over the next 10 to 15 years after the 5-year boundary. Next slide, please. So HeadSmart, I'm going to talk a little about HeadSmart. I mentioned that we started the campaign because we were aware that it was taking about 3 months to make a diagnosis of cancer based upon studies done in various centers. And it was in 1999, we submitted a grant application to the brain tumor charity to ask them for money to put a project together. They initially rejected it because the scientific committee thought this was something that a charity shouldn't fund. And so we resubmitted it to our lottery fund. Go back a bit. We resubmitted it to our lottery fund and were successful. in getting a £100,000 grant to launch it. With that money, we employed somebody to do three things: to do a systematic literature review and meta-analysis of the literature about symptoms of brain tumours, to work with 100 different doctors and develop a consensus survey of the symptoms which should generate a brain scan, and then that was converted into a clinical guideline, which was published by a professional college, the Royal College of Pediatrics and Child Health. When I got that completed, the president of the college rang me up and said, "This is a great guideline, David. Nobody will read it." And so this posed a problem. I said, "Well, what do I do about that?" He said, "You need to launch it with a publicity campaign." So we went back to another charity and got another £200,000 and converted our guideline into a media awareness campaign, and we called it HeadSmart. We had some data that being collected throughout this time period, and I'll show you that data later. We also got the guideline we developed accredited according to the National Health Evidence Standard, which is an important element of quality, and we launched the guideline in 2011. Next slide, please. I'll have to make that shot. So the materials for our first campaign are shown here. It consisted really of 4 components. The symptom checklist, those are the 3 panels you can see in the middle of that slide. There's under 5 on the left, 5 to 10, 12 in the middle, and 12 to 18 on the right. And these are the ranked symptoms of brain that occur in children with brain tumours at these different ages. And these were the advice that were given to doctors to say, if you have one of these, see your doctor. If you have 2 of them, ask for a brain scan. And so we launched that. That was the message we sent out to the doctors, and it's a message we sent out to the public. There was also a media campaign, social media campaign that was developing at that time. We had a website with a decision support tool on the website, and the website also had a training program for doctors and training. We used infographics quite a lot, and this infographic collection is really quite interesting. And I want you to look at the top right-hand panel to start with, the babies under 5 years. Each of them have a set of symptoms, and these are ranked based upon the systematic literature review. And you can see that, and they're linked to a particular part of the brain. This at the top left-hand corner, the yellow area, that's the posterior fossa, the cerebellum. And the symptoms there are vomiting, coordination. It's more on my screen. The next on the right are the brainstem symptoms, and they differ from the cerebellar symptoms. And similarly, the symptoms in the spinal cord, the bottom left, and the symptoms in the middle of the brain, and the symptoms in the cerebral cortex. So providing evidence-based guidance is complex. You can't just put a list of simple symptoms. The doctors need more guidance. And so we use these infographics to help that. The other point, this slide is really important because different specialists see children for different reasons. And they can all see children who may have a brain tumor. Psychiatrists may see children with anorexia and weight loss and think they have anorexia nervosa, but in fact they have a midline supratentorial tumor. And ophthalmologists commonly see children with signs in the eyes that can be due to brain tumor. ENT surgeons, ear, nose and throat surgeons can see children with hearing or balance problems. And so we also felt it was important to give support to the different specialists for how they should select cases for scanning for brain tumor. Next slide, please. Like to have that, that's great. We collected a lot of data, and the data is really important for the campaign because without data, you don't know how effective your campaign is. We had data about how many people had heard about it, and when we launched it, nobody had heard of HeadSmart. By 4 years, 20% of the population across the whole UK had heard about HeadSmart. So that sort of data is really useful for awareness. But the data that we were interested in was how long was it taking different tumours to be diagnosed? And this analysis is really interesting. There are 2 measurements here. The blue blob are the median in total diagnostic interval. That's from symptom onset to diagnosis. And the green blobs are the mean. And if in the distribution of data, the median is a long way away from the mean, that means that the data is skewed in a long way, has a long tail out to the right. And you can see that these tumors, which are different types of brain tumor, have a very much wider distribution much more skewed distribution of total diagnostic interval compared to these. And these are the mid part of the brain. And so they're obviously the group where the longest diagnostic intervals are. Next slide, please. Next, that's right. So this left panel shows the total diagnostic interval in the UK across the whole country from the beginning of the campaign to the most recent time period. And we started off with the median symptom interval, that half the patients were being diagnosed by 14.4 weeks, with a mean being 35 weeks. So there was a big gap between the median and the mean. And then in the most recent time period, the median symptom and total diagnostic interval is 6 weeks, with a median of 18.5 weeks. So over this 10-year period, we brought the total diagnostic interval down from unacceptable 3 months to a more acceptable month to month and a half. There are still delays. It doesn't eliminate the problem, but clearly halving the total diagnostic interval across the whole country has significant impact. This campaign has now been adopted by many different countries, and Scott, who's going to talk later, took it on board in his own state in Ohio. So I'm going to finish in the next with this last 2 slides. This is the program that we're using to develop childhood cancer awareness for all childhood cancers. And this infographic was developed by a mother whose daughter had a leukemia, and the mother was the general practitioner in Britain. And I'll just say briefly how the British health system works. In Britain, most children don't see a pediatrician first. They see their family doctor first, or general practitioner. And that person has to be expert in everything from old age to babies. And so they have a big task. So we're using this awareness as a way of using them in their practice. They then refer to a pediatrician who are normally based in a hospital in their regional pediatric center. And it is that, so the awareness campaign was directed at the GPs and the pediatricians, because they work in partnership to deal with problems for children. This infographic has been developed for all childhood cancers and covers children's brain cancers occurring from the top of the head to the bottom of the feet. And the 4 important things we notice here is that childhood cancer symptoms affect any system. Could you go back? Multiple attendances are a sign that you need to be raising your awareness that cancer may be. GPs and pediatricians need to listen to parents because they know their children best. Interval and delay accumulate. Safety netting applies. So if you say, I want to see your child again in 2 weeks, if they don't turn up, you need to chase them up because you were doing it. And if you're not sure, you should ask an expert. And I think those are the 5 messages that we felt were really valuable. My last slide, if you just go to the last slide. I mentioned at the beginning that diagnosis has become a global thing for healthcare. And this was a conclusion from an article in Lancet Oncology. It was the WHO Commission, and they had identified childhood cancer as a strategy globally. And they want to enhance the outcomes for children with cancer so that across the world, 50% of children are being cured across the world, which will be a massive improvement in outcomes when you compare to the current statistics. And they've estimated economically that for every $1 you invest in children's cancer, you have the capacity to get $3 in return. And when I read that, I felt that this was a really powerful argument for healthcare systems to take children's cancer seriously. And at that point, I'll finish. Thank you very much.
We'll now hear from Dr. Scott Coven.
Thank you very much. And I also appreciate the organizers for inviting me and having the opportunity to speak alongside Dr. David Walker. I have had the unique experience of really being impacted by the work that is ongoing in the UK starting in 2014. And hearing the presentation about Head Smart has impacted what I've done, here to date so far in the United States. So if you go back to the previous slide. So, we use some of David's and Sharna's guidance over meeting time and other time to really, lay a foundation to collect some of the data in the United States. We've done that for both pediatric brain tumors and children with leukemia, and have found that the data supports, what David and Sharna originally documented, which is, the time interval is somewhere about 6 to 9 weeks. And that's for all kind of pediatric brain tumors. And, there were some landmark studies done in the 80s and really show almost no different change in that time interval over the past 30 or 40 years. As I've transitioned to Indiana, I've tried to bring this work, expand it to the Midwest using a similar platform and media awareness campaign and infographics, as David had mentioned previously. And we've provided many grand rounds presentations in Ohio and throughout the United States to really provide, some motivation and forward momentum for this. And I think I can then speak to some of the issues that have held us up and the differences between our health system and, of course, the United Kingdom health system. Next slide. So, some thoughts that have gained, in my mind over the past 7 years of doing this work. When we've put in for grants, the responses to us are, we know what David and them have done in the UK, but how do you know that those delays in diagnosis impact true outcomes? And while I know they impact outcomes, I think our parents tell us they impact outcomes. We see it. And I'm seeing it more and more where the distrust that a parent has once a diagnosis or a delay occurs, I think persists well on past completion of therapy, even further than that. And I, as I've met with Stephen Crawley and others on this call, I hear those concerns, and I think that is a lens that we need to keep in mind as we think about this. But how are our general pediatricians here in the United States, since they are experts in pediatric care, how will they accept this information? Do we need the data to really support these outcomes, the mistrust or distrust? Go back one slide, sorry. One other thing is utilizing our electronic health records. We have, great momentum with electronic record keeping now to investigate and use artificial intelligence or informatics or other computer science software that can build risk prediction models, that can build, clinical decision support tools. And some of my work is not only in the awareness portion, but is trying to investigate, how do delays, how do these other risk factors, are there ways to really pop or show a pediatrician in real time that this is a child that needs more workup, right then and there in real time. And then how do we really engage primary care providers? I think David, highlighted in the United Kingdom, it was kind of a lack of education. What I'm finding as a subspecialist, I'm aware of the problem, and I've been thankful to meet, Stephen and Susan and others who are aware of the problem. But I think now engaging the primary care providers, the family practice providers, the emergency room physicians, and figuring out how to be partners with them and how to open those conversations, how to help us understand how to work together as a collaborative group. And I think that's what we're looking for from you all as members of this group. Next slide. So, these are just a few questions that I'm kind of posing, and I think David has helped me craft some of these questions as I've thought over the past few years. But it's, how will a program like this work to reduce delays in diagnosis in the United States? Head Smart has not really caught on here in the United States, through grant applications, although from some local support through smaller organizations that may even be on this call have helped us to get some funds to do the work, to do some of the infographics. But we're a big country, and trying to do this in isolation is not the ideal way. And I'm thankful for Susan and others who are now trying to build this together in one momentum instead of, a Midwest version and a West Coast version. And I'm hopeful today we'll get more partners who will move this forward together instead of just in isolated pockets. I do think the program collectively, though, will work to reduce delays. Will this program play a role in improved advocacy and awareness? Without a doubt. I mean, we certainly, when we've gone out and done grand rounds presentations, the PCPs are just thrilled about this information. But it's how do we on a global level engage when, the American Academy of Pediatrics may not have the bandwidth to take on a lot of this work. I think it's up to us to bring the work, finalize the work, and then bring it to them and say, hey, this is in final mode. Now let's take it out, and how do we disseminate it? And then lastly, and I've heard David use this, is like, Scott, how do you think about Stand Up to Cancer and how it has a global vision that isn't isolated just to the United States? And so what I've always thought and preached is, why is there no Stand Up to Cancer Kids? Why does this not exist? And it should exist. And again, as a specialist, I want that meeting with parents from the beginning to not be in a setting of mistrust or distrust because a delay has started their whole process. I want them to have an accurate, on-time diagnosis that is built out of trust and transparency that then brings them to me as the subspecialist, and that relationship continues, and then they go through therapy, and then they continue their survivorship journey in a very trusting, open relationship. So I think that, to me, are the major questions on how we move this bar forward. Next slide. I'm happy for anyone to contact me. My email is here. And something that David said early on in this process that's resonated with me, that how HeadSmart was successful was a parent advocate. And as David knows, for the past 7 years, I've never had a parent advocate. As a subspecialist, I've really done this on my own, going out in the communities to try to make a difference. And I'm thrilled that this year, finally, 7 years into this journey, I've met Stephen and I've met Susan Gusto, who are just as passionate about this as I am, and now recognize that we're building a small army of individuals who are really interested and will go to the ends to really make this a reality. And so, I'm thankful that Susan is going to share some of her work today as well. She's a founder of Friends of Catherine, and just over the past 2 months has become a dear friend. And I'm really thankful that, we've gotten now some of this together and now need this final part of general pediatricians and more lay individuals interested in moving this bar. So thank you for your attention.
Thank you. And I don't know if my camera is on, Robin.
I cannot see you, so I don't believe so.
Yeah, you can hit the where it says webcam there.
I've got that. I'm pressing that. There we go. Hello, everybody. I'm so happy to be here, and I'm so happy that we were able to introduce David and Scott to some of our peers in the children's cancer world. Just a tiny bit of background on me. I am a mother of a neuroblastoma survivor. She went through treatment in 2008. She's currently 17, and I'm thrilled that my daughter's oncologist is also in the audience because she touches on this important fact of parents being partners with the pediatrician. So it's like P cubed. This graphic represents some of the work that we've done in the last year with Amy Sapien and Steve Crowley and Cynthia Van Latten, who are this little tribe of parents that we put together thanks to Vicki, the introduction of Vicki, to those of us saying, hey, who else out there in the parent world is looking at diagnosis as an issue? In the background, we had my daughter's pediatrician had missed her diagnosis for a few months. And that kind of led me to start thinking about this as an issue. And about 8 months ago, I started doing some surveys with neuroblastoma parents and found that I wasn't alone. I would say at least 50% of the people that were involved with the neuroblastoma parent group had been affected by delayed diagnosis, and they had a lot to say about that. So I did some surveys, I got some incredible data, and it resulted in where we are now. When we talk about parents and pediatricians becoming partners, it is kind of a tricky dance in that most pediatricians will never see a case of neuroblastoma or children's cancer in their career. It could be 1 to 3 cases maybe that cross their desk, come through their door, and they just don't always know what to look for. Those kids that are coming in with a limp, or the kids that have a backache and it's unusual, or the kids that are moody for no reason. Those symptoms are super confusing to the parents and to the pediatricians. But when they are joined by other symptoms that are recurring or that are so unusual, it deserves a closer look. So what we're trying to do initially is to get the word out to the pediatricians that we know it's confusing. It is a partnership, we're not blaming, but we do want to build awareness amongst pediatricians who are new or pediatricians that have been in practice for 30 years that sometimes those symptoms could be cancer. Children's cancer diagnoses are on the rise. And so it's worth reminding these people that may have been out of med school for a long time that those symptoms could be something more serious than a growing pain or a strained muscle. It's hard to see all the verbiage on this graphic, but this graphic is basically something that we would share with pediatricians, and it talks about the diagnosis pathway that is down there in the right-hand corner, and that is basically showing where those intervals are or the delays in the parent getting the child into medical care, and then that's where the delays occur because we can't, the medical provider can't figure out if this is cancer. Our delay was 7 months. Did my daughter's cancer spread during that time? I don't know. She was metastasized all over by the time we got it. And that is where we want to improve the communication with physicians so we can reduce that delay. Next slide, please. And this is like going from the Grace Kelly Foundation in the UK. This is an infographic for the US where we understand that it's very rare. We understand that it's not going to be in every pediatrician's career that they're going to see a child with cancer, but could it be cancer? And these are some of the symptoms that actually cross not only neuroblastoma, but many of the symptoms that were recorded and then shown in graphics from the Grace Kelly Foundation. It covers some of the symptoms of brain cancer, leukemia, Ewing sarcoma, osteosarcoma, and just things that a pediatrician normally wouldn't say, this could be cancer. And we're calling upon the pediatricians to be a little bit more actively engaged, and something as simple as something they've done in the UK, which is to set up a plan of, it's not unusual. It's kind of weird that your daughter's having a backache and she's 4. Let's set up a plan for 3 weeks from now to get her in here. Or I understand that you're saying that your 3-year-old isn't keeping up with her peers and maybe she's tripping. Let's get her back in here in a couple months. And just that active engagement with the parents to listen to what they're saying. As Scott had said, one of our goals is to do what David had done in the US or in the UK so successfully, which is to really make it a point to ask the doctors to listen to the parents. Because as reported in one of the surveys I did, when you ask the parents what the top 10 symptoms were that their child experienced leading up to a cancer diagnosis, they did not link up with what the COG or the American Association of Pediatrics is saying are the symptoms to look for in a clinical presentation. The parents are talking about behavioral changes, mood changes, unusual behavior, mood swings, tantrums, crying, screaming at times. And I know personally my daughter did all of those things, and her diagnosis was still missed for 7 months with an excellent pediatrician. So this is taking the words of all these parents that we have surveyed, hundreds of them, and putting it into writing to ask the pediatricians to work with us to help us spread this word through ongoing education, through what we call tip of the month at the USC Medical Center, which we're trying to get out to their residents, and just to open their eyes to the fact that this is something that is a global health issue. It affects people in suburban and urban areas, and it's just critical to improving the outcome of children with cancer that we diagnose it earlier. So we'll share more information on this, and I'm going to now toss it over to Steve Crowley to close us out.
Great, Susan, thanks. So yeah, just briefly, we want to allow some time for your questions, but just thinking concretely about next steps we might be able to take here. One is certainly getting the American Academy of Pediatrics to issue some clear guidelines. We've seen some great infographics from David Walker's team, just something ready at hand, reference materials in pediatrician's office. Now, this is kind of the gold standard. And I think, as Scott suggested, this might be the last step. Perhaps we have to build up to that before we can get there. Another goal is simply to have these guidelines available for medical schools, particularly for students who are going on to general practice or pediatrician specialties, pediatric specialties. We could certainly work to introduce these guidelines and reference materials at the state level to start off, build again to the national level. We can work to make sure the pediatric cancer diagnosis is part of the continuing education for board certification for pediatricians. This is something that Amy Sapien has been working on. And among other things, simply research. This is something that we've learned from speaking with Scott Coven. Research in this area would not be costly, but it would we need to ensure that research is happening here the way that it's happening in the UK, as it is with David Walker team. We just need some basic data. Again, not difficult to get a hold of, but we just need to make sure that happens. So maybe we'll stop there, and we want to thank our speakers, but we will open this up to your questions.
Just whilst people are thinking of their question, could I make one important point? Susan, you talked about the sensitivity of your pediatrician, seeing that he or she may never see another child with neuroblastoma. And that is because you've got a good relationship with your pediatrician and you want to protect them. But actually, children's cancer affects 1 in 400 children under the age of 15. They need to be thinking about cancer as a differential diagnosis of every child they see. It may be a long way down the list, but it's there. And the defense that you'd hardly ever see one is not true for two reasons. One is pediatricians do see cancer all the time, probably every month. They're just different ones. And the second thing is the risk is for the child, not the doctor. With modern medicine, we get more and more doctors. We seldom see the same doctor twice if you go to our family doctor. And the risk, therefore, is for the patient. And so I think you need to communicate the risk from the patient's perspective, because that defense of I hardly ever see one is used in the law courts to excuse people not knowing something. But every doctor who's been trained has answered questions in their exams about childhood cancer. Scott, you correlate that with me. We've all had to be knowledgeable in this subject, so it isn't something they don't know about. The problem is every textbook says childhood cancer is rare, and those data I showed demonstrates that it's not. It's maybe rare under the age of 5, under the age of 1, but it's actually 1 in 1,000 children. That's 1 or 2 children in every state school will have had cancer by the time they're 5, and maybe 2 or 3 of them will have had cancer by the time they're 15. So that's not rare.
Good point.
And I think, and Susan, we've talked about this. A lot of it is awareness, but a lot of it is the communication aspect. How do you frame a conversation that says, I don't think this is cancer, but it's still, I'm thinking about it, and let's just have you come back in a few weeks versus this is absolutely not cancer. That conversation and the use of similar words is a vastly different conversation between what a parent hears. And a parent is going to accept a conversation that says, well, my pediatrician's listening to me. They understand, I'm worried about cancer. They don't think it is that, but they're asking me to come back and contact them, if I'm still concerned. That's a very powerful conversation versus saying it's absolutely not cancer, don't worry, which is what we hear a lot of the times that our pediatricians say.
We definitely had that. We have a person in our group who had a child that had pretty severe leukemia, and the pediatrician had said, well, we know this is definitely not cancer. And a few days later, the child passed out in a store, and it was leukemia. Yeah, we heard so much from parents in the surveys that we did, and the symptoms that were excused as constipation, leg pull, trying to get attention. And what we're trying to do is to build awareness that you've got to open your mind that it could be cancer because it's on the rise, and it's every parent's nightmare, as all of us that are affected by it know, but it just could be it. And I know when one parent in a community has experienced this, every other parent's antenna is raised, and we become that parent that becomes everybody's worst nightmare. And it's something that pediatricians need to consider for sure. I know our pediatrician told me 2 months later that her antenna was raised, and she did then successfully diagnose a little boy with brain cancer that otherwise she said she would have probably not been tuned into. So yeah, the education is critical.
When we launched the Head Smart campaign, we came out with those lists of symptoms, which were all evidence-based. And the fact that they were evidence-based meant that the physicians respected them.
Mm-hmm.
And I got the unexpected reaction. The doctor, who some people I knew very well, who were very good doctors, said, the good thing about your card is that if they don't have this, I don't need to do a brain scan.
Mm.
And so they turned the evidence on its head. I would written the evidence to say, these are the ones you need to scan. And they turned it on the head and said, look, most people don't have cancer. So if they don't have these symptoms, I don't need to do a brain scan. And that's a really powerful tool, because the Academy of Pediatricians will say, we can't have you worrying about cancer in every case, because 99% of the children don't have it.
Yeah.
They'll play the rare card. But if you say, well, look, we've got the evidence base, and if they don't have these symptoms, it's reasonable to wait and see. But if they do have these symptoms, you need to do the ultrasound scan, the blood test, the urine test, whatever it is, to diagnose the cancer in that bit of the body that's not working properly. And I think that's the message here. It's actually not about rarity. It's about being specific about symptoms. And so I think if you can work with the Academy of Pediatricians, the evidence, we're doing more research, doing more systematic literature reviews. They will be published. Anybody can use the data. We don't own it. We put it out there. It's actually recording what everybody else has recorded previously. So it's easy access. It's about people saying this is worth doing because we become better doctors as a result.
Mm-hmm. Absolutely.
One of the things that was really heartening, I think, for us to see your work, Dr. Walker, and you showed it in your presentation as well, was just taking parents' concerns seriously. And that was really quite striking, because we hear that again and again, the sort of parents knocking their heads against the wall. But just the fact that these infographics exist, it's the fact that there's these clear, concise guidelines that are just readily available exist, and we just, almost need to just carry them into pediatricians' offices. So we have to figure out the effective way of doing that. But this does not seem to be an insurmountable hurdle, and it would seem to bring about a huge amount of benefit if we can make that happen.
And it's really inexpensive. It's inexpensive and effective to send an electronic file or to physically drop something off.
We distributed nearly 5 million of those symptom cards across the whole country. They've got into kids' school bags. They were given when babies were born in the bags that they take away from the maternity unit. They were distributed widely, and people started turning up and doing just what you said, Stephen. They said, I've got this card. Do you think it could be a brain tumor? And once they do that, the doctor stops saying, there's nothing to worry about. He says, I'll refer you now. And we had lots of stories where people saying the card broke the ice. It stopped us having a dialogue which was not agreeing with the doctor, to the doctor say, well, this is a guideline, I better do what it says. Because, it could be anything from, when you're doing a very wide range of diagnoses, a concrete piece of evidence is very helpful, isn't it, Scott? When you're sitting there, you don't know what to do, and someone says, well, the guideline says do this. Well, at least that's a safe thing to do. And doctors like it.
And we understand these pediatricians are busy. They're seeing 30 kids a day, and one may have these, or 10 of these kids may have similar symptoms, and deciding who needs more workup, who doesn't. And I think, again, you helped me frame a lot of the grand rounds presentations to say, look, this is helpful not only when you're worried, but also to reassure families, to provide reassurance and say, hey, look, I'm not actually that worried because the guidelines support not doing anything further. But if worst case scenario, you come back in a week or two, and we'll be in contact and we'll be able to move forward. David, one of the questions I was going to ask you is, have you been successful in, besides HeadSmart, pushing forward, an online like learning module, or, things of that nature? As I was sitting here thinking, I took some notes, as Susan's talking about medical school, but, is there a way to build a 3 or 4 part module going over some of these more common cancers with symptoms that actually engage, you have a parent panel, right? You have some of the subspecialists giving a part. It'd be great to have a pediatrician, as part of that on some of these teaching modules. Have you perfected or gotten to a part where you've been able to do that yet?
We've done that for brain tumors. So we've got training modules in brain tumors. We hope that the Child Cancer Smart program is progressively developing, and Shana, who's working on that, she wrote the modules for the brain tumors. So she's got a lot of experience. She's trained in education, and she's not an oncologist. Because to be honest, the oncologists aren't interested, and Scott's quite unique. The oncologist, because he worked for an even more unique boss. But but the oncologists aren't interested because they deal with what happens. But they should be interested, because if they want to use less therapy, have better outcomes, having an early diagnosis is the way you do it. And the molecular biology now is such that we could be screening the population for cancer. So at the moment, we screen the population for cystic fibrosis, for hypothyroidism, for inborn errors of metabolism, as in the first week of life. These cancers, by and large, are developing during embryonic development. And there's growing evidence that the genetics are detectable around the time of birth, and all you need is the right sample. And so we could be diagnosing these problems pre-symptomatically. But that's a big leap because of all the fear that inevitably will happen in society. But I think the technology in Scott's career, it won't happen in my career has ended, but in Scott's career, it will start to happen. And that's actually will get the research funders interested if they can see it as a population. But it's a problem for health, not for oncology. And I would say the Academy of Pediatricians are the right people. It's a child health problem, not the oncologist.
It's a public health problem, and it's not just a global health problem. It's a public health, aspect.
I would like to also touch on the fact that when you talked about artificial intelligence and electronic patient records, there is an organization, it's a company in Canada based out of Toronto called Cure Health, and they are developing with their national health system, they have developed an AI platform that will help their physicians to detect symptoms that then could be leading to a cancer or rare disease diagnosis. It resides in their national healthcare system, and they have algorithms that they're developing for over 7,000 rare diseases. We've worked with them, so neuroblastoma now has an algorithm that is sitting on a pediatrician's platform. So if they're plugging in different symptoms that this child is experiencing, including behavioral changes, it will notify that physician, call back, Ann Smith, because her daughter's symptoms could be this, maybe schedule a follow-up appointment, not to create an alarmist environment, but to help the pediatrician figure out that, of the 50 patients I saw today, I really need to pay more attention to what's going on there. That platform is going to come to the US at some point later this year. They were just bought out by another company, but it is one step closer to using artificial intelligence and technology to diagnose rare diseases, including children's cancer.
I'm sure that's the way for the physician. That's the sort of system. Sometimes they turn that pop-up thing off because it ruins their day, because it keeps on telling them things that they don't want to. But for pediatrics, because not many children get ill, and they do have some diseases that only happen in childhood that don't happen in adulthood. But for pediatricians, that usually I think it's a very good way to go.
Mm-hmm. Yeah, they're trying to get a beta test here in the US, so we're working on that with them.
Thank you so much, Susan, and to everybody that's been on our panel today. I think, for our purposes, it's really important to think about, what can our members do to help support this valuable work that you're doing. And, the infographic that's been developed, and One of the questions that I had personally was, is there a role as we're doing some work at the state level to help get the departments or the state health departments involved in your work? And is that an appropriate way for advocacy to happen?
I would say yes, for sure. I mean, one of the things that Steve points out in that last slide is state boards. And, you know, because our healthcare system is so disparate compared to the UK and Canada and some of the other countries that have adopted Head Smart and Cancer Smart. Yes, I mean, we would be very interested in helping to advocate on the state level, whether it's distributing these infographics like they did very easily in the UK, and developing just some very easy material, whether it's through an online presentation that we can share. I think one of the things that's very important about this is something that David touched on, in that it's really having a voice and a face behind the cause, because most of us that are in CAC2 have a real personal connection to children's cancer, and that being our child or somebody close to us was affected, and therefore the family and, you know, everybody around them was affected. And some of us choose to become advocates, like, you know, Steve and Amy and Cynthia and I have, and working with Scott Coven, you know, a physician. I think it really helps to share stories of and real life examples versus reading a case study in a textbook or looking at an infographic. If we can help you to advocate at the state level with the availability of our experiences and our data and our research, I think I speak on behalf of our little team that we would love to. And we'd love to partner with the people that you have signing up to work with each state to bring our, you know, our cause to them. So yeah, I mean, the more the merrier. We're ready. I mean, we've been kind of talking about this for a year. Steve and Cynthia and I met, you know, right before COVID hit. And so, you know, I think we've got enough materials now, and we'd love to garner just more support at any level. So yeah, just contact me. I think I sent my email.
David, can you give it? Oh, go ahead. Sorry.
I was going to say we're getting close to the top of the hour. I did want to just share that, you know, we have had, I apologize for my dog. We have had some individuals share their stories in the chat, and if they can you share your email address, Susan?
Yes, I did. It's and for those that can't see it, you can send me an email at Susan, SUSAN, at FROCS, FROCS.org. And our organization is Friends of Catherine. So Susan at frocs.org. And I'm happy to. Sorry.
I think, I'm sorry.
No, go ahead.
I was going to say, I think it's really important for our members to know, you know, how they can help and who they can contact in order to help forward this work by using their stories, by using their connections at the state and federal level.
Yeah, thanks, Ann. Yes, feel free to contact me, and we'll continue to work together to support you.
I was hoping that David could get a last comment on about how, you know, in the UK, they've been able to crystallize all this under one umbrella, you know, and so everybody's moving in one direction. And that's been really exciting to see. My concern as a physician, not doing everything in isolation, and how do we as a community make sure that it's not just Susan in the West Coast and Stephen in the Midwest, and that we're actually, you know, is it another nonprofit organization? I don't think so, but is it some type of working group that helps crystallize that, so it's not us all moving kind of, you know, opposite or you know, other directions?
Scott, that is why I turned my camera on. I actually had a question for Susan and Stephen and Amy's in the attendee room. Have you crystallized a project or an initiative, not just, oh, we've got to do everything we can, but at some point, if you come to the point where you've honed in on, if all the foundations and individuals at CAC2 did this, that would be great. But you could either start as an initiative that you just invite like-minded people within CAC2 to work on, or that you bring to the project incubator. Are you that far along in your thinking about what you would really like the members to focus on?
I'd say we're very close. Right now we have a working group. So this is the working group here. But we are very close to getting concrete steps. Again, we've laid out 5 right here. But right now we're looking for folks to join us and to help further strategize. But but moving on to the project incubator, that's probably an excellent idea. And I'd say we're very close to doing that.
Steve and Susan, if y'all would just create a blurb for the June 1st announcements, we'll about your working group to make sure people can join. And I'll talk to you offline about team time at the annual summit, because I think that you can reserve a breakout room on Friday afternoon to talk to people about what you've got going on.
Okay.
Great.
If I could just say one final thing. The thing that we found made the biggest difference in talking to the doctors was we asked them how long it took on average to diagnose a brain tumor. And they all said 3 months. And that's how long it really took. And we asked them how long would they expect, would they think it was ideal for one of their friends or relatives' child to be diagnosed. And they all said about a month, or sometimes 2 weeks. So what you have to do is somehow people from the, I can wait a long time to see if this matures, to actually, if this is a brain tumor, I better do something about it. And it was about that change from, you know, it always takes 3 months to make a diagnosis, to actually it matters. Because if you've got meningococcal septicemia, they know that if you don't act and give them antibiotics, they could be dead in 4 hours. That with a brain tumor, if you don't get them in time, their brain is progressively being damaged, which means that in the long run, there will be a less successful individual, even if they're cured of their brain tumor. And they need to kind of see that their job is to reduce the brain damage.
Yeah. It's always interesting when you bring it back to if this was your child.
Making it personal, that's so important. I'd like to thank each one of you, Dr. Walker, Dr. Cohen, Susan, and Stephen Crowley. Thank you so much for organizing for us today and sharing this important work. And as Vicki pointed out, I hope to see your work move forward, and especially through a breakout session at the annual summit. So thank you all, and
thank you.
Hopefully we'll get this up, this recording up onto the website shortly.
Great.
Have a great day.
Thank you very much.
Thank you, David. Thank you, Scott.
Good luck, Scott.
Thank you.